My name is Sarah Godley. I am a Vice President of Advisory Services with Career Physician, and I'm grateful for all of you joining us this afternoon. Today's session is part of our Pediatric Insight series, which is presented by our Child Health Advisory Council. If you are unfamiliar with this series or were not able to attend our previous sessions, you can find those on careerphysician.com in our under the Advisory Council tab. We have links to the previous webinars. Today is the first in a two-part series focused on leading in pursuit of racial equity. Today is part one, and part two will take place on June 10th. We will send out a registration link with more information for that at the conclusion of today's webinar. And then finally, I want to mention that we do have plenty of time allotted for questions and discussion at the end of the session today. So if you would use the raise hand feature within Zoom, you can raise your hand, we will unmute you so that you can ask your question or provide your comment. I'm going to turn it over to Wesley Milliken, who is our CEO at Career Physician, and he will introduce today's speakers as well as our Child Health Advisory Council.
Sure, thank you, Sarah. I appreciate everybody joining this crucial conversation in my book. I think it's an imperative conversation and one that we're happy to partner with the Child Health Advisory Council on. I feel like, we being a leader in child health executive search and leadership development, and we need to do a bit more as a company to more than just search. And so, I want to thank Dr. Stapleton for chairing the Child Health Advisory Council and all of our advisory council members for joining in on this conversation. For the audience, the collective group shares a real passion for leaving a legacy of leadership in academic pediatrics and really looking for ways like this conversation today to harness the wisdom of one generation and pass it on to the next. And so it's something we will continue to be passionate about as we go forward. So, with that said, I want to welcome Renée Jenkins and Tiffany Johnson to the conversation. And Renée, I know you plan to introduce Tiffany, so thank you both for your commitment to today's program.
Okay. Well, good afternoon to all of you. I'm Renée Jenkins, as I was introduced. And the Child Health Advisory Council is really pleased to bring you the Insight webinar focused on leadership and the pursuit of racial equity. I will share a few introductory comments, followed by Tiffany Johnson, our guest presenter, whose research expertise is on the impact of racism and health. She will give us a view of the root causes of pediatric disparities and some strategies on how to move forward to achieve equity. Next, Dr. Bruder Stapleton will speak to his experiences on working to achieve equity. We'll then pose several questions to stimulate an active discussion on the strengths and acknowledge that there are risks involved in the next steps in achieving racial equity. The focus for this webinar was really generated by the following observations and events. For one, the browning of America, with non-white children comprising almost 50% of the child population. As a result, failure to address pediatric health disparities will increase the proportion of children affected. Witnessing the murder of George Floyd and the aftermath that followed around the world. The horror of that witnessing served as a catalyst for much of the anti-racist work that is now being attempted in the pediatric academic community. The outpouring of statements condemning racism with little to identify the process to get to the specific next steps is number 3. And the question is, how do we mitigate such practices and achieve equity in child health? So what you see before you are the learning objectives that we're using today. Which are the following, as you can see. Describing the opportunities for leaders to create a safer and more nurturing environment for the diverse faculty, trainees, students, patients, and their families. We really want to create a bidirectional dialogue following the presentations on how we can move forward to mitigate racism in healthcare with an emphasis on clinical practice this session, and it will be on research the next session in June. But we also recognize that there are impacts on medical education, advocacy, and workforce diversity, which will come into our discussion, but not as big a focus as the issues on clinical and research. And then last, we really want to identify some resources for continued learning and self-reflection on the topics of racism, privilege, white fragility, and anti-racism. With that, I'll turn it over to our guest speaker, Dr. Tiffany Johnson.
Thank you so much, Dr. Jenkins. I'm going to go ahead and share my screen with you all today. All right, so Dr. Jenkins provided the overall objectives for this hour-long session. The goal of my presentation is to really just do some level setting before we get into the more interactive discussion. So I'm going to first briefly describe some of the disparities that exist in pediatric healthcare and outcomes. And then next, I'm going to review what some of the root causes of these disparities are, focus on racism. And finally, I'll suggest some steps that pediatricians can take to address racism as a public health crisis on a path towards achieving equity. So while the stark disparities in healthcare and outcomes that have been exposed by the COVID-19 pandemic have received a significant amount of attention, this is an issue that we've really been facing for quite some time. So more than a decade ago, Glenn Flores and the AAP Committee on Pediatric Research published a systematic review which identified disparities across the entire spectrum of pediatric health and healthcare. And what they concluded from this review was that disparities are quite extensive, pervasive, and persistent. And unfortunately, these disparities continue to be uncovered in the pediatric literature. So for example, disparities are very well documented for pediatric surgical care and outcomes. So in a study that was performed by the Pediatric Emergency Care Applied Research Network, or PECARN, which I'm actively involved in, we found that Black children were more likely to have a delayed diagnosis of appendicitis with a prior visit where appendicitis was missed. They were also less likely to have any imaging done, such as a CT scan or an ultrasound during that prior visit. So this study suggests that when Black children come to the ED, physicians don't trust their pain. We're less likely to perform the necessary evaluation to work up their pain, leading to delays in diagnoses. And other studies have also found that we're less likely to give Black children analgesics to adequately address their pain. And this is true for more subjective presentations like abdominal pain, as well as more objective things like long bone fractures. But perhaps even more concerning is a recent study published which found that the risk of post-operative mortality for apparently healthy Black children was about 3.5 times higher compared to white children. Disparities have also been very well documented in child abuse evaluation and reporting. So for example, in one large urban academic trauma center, they found that Black and Hispanic children who presented with accidental fractures were more likely than white children to undergo a skeletal survey with an odds ratio of 8.75, and they were more likely to be reported to CPS with an odds ratio of 4.32. Additionally, we also recognize that abuse is more likely to be under-recognized in white children. So an analysis of known cases of abusive head trauma, it was initially missed in 37% of white children in comparison to only 19% of non-white children. One of the most striking disparities that I've seen published recently is in looking at infant mortality. So these investigators found that Black newborns die at 3 times the rate of white newborns. But results indicate significant improvement for Black children when there was racial concordance and they were cared for by Black physicians. So these results highlight the need to improve physician workforce diversity, but it also generates new questions about how we can ensure that all newborns receive optimal care, regardless of their race and regardless of the race of their provider. So now that I've highlighted just a few of the disparities that have been reported in the pediatric literature, next I want to spend some time examining their root causes. So I'm going to use this social ecological model that explores factors at the community and healthcare system level, and then within our healthcare systems, what happens at the level of the patient, parent, provider triad. So first, when we take a look at the big picture here, when we think about disparities in pediatric healthcare and outcomes, racism is an important root cause within each of these concentric circles. So racism, as defined by Dr. Kamara Jones and cited in the AAP policy statement on racism, is defined as a system of structuring opportunities and assigning value based on the social interpretation of how one looks. And I think it's important to highlight that race is a social construct and not a biological construct. And what it does is it unfairly disadvantages some individuals in communities, and at the same time, it unfairly advantages other individuals and communities. So these unfair advantages are white privilege. So I want you guys to think about what are some of the ways in which you have received unearned and unfair advantages from being white or from your proximity to whiteness. And some people talk about like using their privilege for good, but as we get towards the end of this presentation, what I instead want you to do is think about what are some of the ways in which you can dismantle the structures so that you no longer have unfair advantages while others have unfair disadvantages. And the reason why this is important is because what racism ultimately does is it saps the strength of the whole society through a waste of human resources. As we think about this definition of racism, I also think it's important to note that racism exists on many different levels, including structural racism, personally mediated racism, internalized racism, and vicarious racism. So I want to spend a little bit of time talking to you today about structural racism. So this refers to your policies, laws, and regulations that exist on a local, state, or national level that result in differential access to goods, services, and opportunities based on race. So one of the most salient examples of structural racism that we see is redlining, which refers to when the Federal Homeowners Loan Corporation literally pulled out maps and drew lines in red ink, marking neighborhoods as hazardous based on racial demographics. And what this did was it led to the systematic denial of capital investments, which could have improved the housing and economic opportunities of residents within those communities, subsequently leading to what we see now as healthcare deserts and food deserts and transportation deserts and limited green spaces. And even though redlining is now illegal, many of these historically redlined communities remain low-income neighborhoods today, and they remain communities of color today. And beyond structural racism in communities, next in our social ecological model, we need to consider factors at the level of the healthcare system that may directly contribute to disparities. So I think it's first important to acknowledge that the mistrust of healthcare systems and research that exists among Black and Indigenous people of color is well earned, with many examples of Black and brown bodies being exploited in medicine and research. And then beyond medical experimentation, it's also important to acknowledge that the roots of healthcare in this country includes segregation of care based on race. And there are still ways today in which care is segregated based on insurance and the socioeconomic status, which remains deeply entangled with race. So medicine and science need to be held accountable for these historic injustices, and they also have to be viewed in light of the present day injustices, such as the disparities that I've highlighted today. I also want to acknowledge the role of personally mediated racism when we consider factors at the level of the patient, parent, and provider triad. So personally mediated racism comes in several different flavors. Beyond overt discrimination, you also have explicit bias and implicit bias, which further contributes to the well-earned mistrust among patients and families. So one great example of explicit bias in healthcare that I like to use is in this study, which was done among medical students and residents, and it was published in 2016. And so in this study, half of the participants reported having at least one false belief about biological differences between Black and white individuals. So this includes beliefs that Black people have less sensitive nerve endings, thicker skin, and stronger bones. And this is important because among those who reported having these false beliefs, they were also more likely to rate Black patients' pain as lower and make less appropriate treatment recommendations. So I want you to think about this as we tie it into some of these disparities in analgesic use that I previously described. So next we have implicit bias. So implicit bias refers to those attitudes that lie below the surface of our consciousness, but they can still influence our behaviors. So what I'm going to do is briefly share some of the research that I've done looking at implicit bias in the pediatric emergency department setting. So in this study, we looked at implicit bias towards children versus adults. So for this, we use the adult race IAT, which has these pictures of these Black adult faces and white adult faces, and you have to link those faces with words that represent good or bad. And this is the adult race IAT is the most commonly used implicit association test in the literature. But then there's also this child race IAT that has these pictures of these Black children and white children. And this one was actually developed to give to children children to determine when children develop their biases. But as we're pediatric providers, I was interested in looking to see if our biases are different towards children in comparison to adults. So we administered this to 91 residents who were working in a pediatric emergency department. And what we found was that 85% of our participants had a pro-white, anti-Black bias on the adult race IAT, and 91% of the participants had a bias against Black children. So what this study shows us is that, number one, pediatricians aren't immune to having bias, but more importantly, our pediatric patients who are showing up in the healthcare systems, they're not immune from experiencing bias from providers. And then next, in this study, we also looked at implicit bias towards names, for example. So this was a study that was done among 54 fellows and attendings who were working in a pediatric emergency department, and included pediatric emergency attendings as well as trauma physicians. And we found in this study that 60% of participants had a pro-white bias favoring stereotypically white-sounding names like Heather and Brad versus stereotypically Black-sounding names like Jamal and Tamika. And so this is important because when considering that our biases can be activated even before we walk into a door for a clinical encounter based on looking at the patient's name in the EMR. I'm going to go back quickly because I think I may have skipped over another slide looking at our implicit bias and cognitive load. So in this study, we administered the implicit association test to participants before a shift in the emergency department and after a shift in the emergency department. And what we found was that among participants who were caring for more than 10 patients during their shift, their pre-shift IHE score was 0.33, and that increased after their shift to 0.63 for a mean increase of 0.17 that was statistically significant. We also found that when the ED was more objectively overcrowded, that there was more bias at the end of their shift, going from 0.34 before the shift to 0.57 after their shift for a mean increase of 0.09 that was also statistically significant. So I'm glad that I went back to this slide that I skipped over by mistake, because this is really important because I want you to think about your day. So I know one of our panelists today said they just got out of clinic. So I want you to think about when you start your day. And when you start, you're hopefully well rested, possibly well caffeinated. Hopefully you've also had a chance to have some breakfast before your shifts, before your workday starts. And so you're coming in hopefully at your best. But then think about how you're feeling towards the end of the day, right? So maybe things were so busy in clinic that you had to skip lunch that day, or you've just had to see lots of different patients, face lots of different challenges, made lots of different decisions. And so what this study shows is that the more decisions you make, like the more difficult each subsequent decision becomes. And so your biases are more likely to be activated towards the end of your workday as opposed to the beginning of your workday. So I want you to think about how this impacts who you're prescribing pain medications to in your clinics, for example, who you're working up for appendicitis when you're in the emergency department, and how that bias can come into play once you've experienced a significant amount of cognitive load. And so these three studies are a part of a growing body of literature examining implicit bias in healthcare. So in this systematic review of the literature, we found that similar to the general population, most healthcare providers have an implicit pro-white, anti-Black bias. So going to medical school and becoming a physician and going to pediatric residency even don't make you immune from having bias. It's very similar to the general population. But what was also really striking in this review were the robust findings that when we examined real-world patient encounters, there was a robust association between implicit bias and provider communication. So physicians who have higher implicit bias also demonstrate higher verbal dominance in their communication style, less interpersonal treatment, less supportive communication, and less patient-centered communication. And the reason this is important is because even when our biases are implicit, patients are picking up on provider attitudes through our verbal and our nonverbal cues. So patients of providers who have more bias also reported poorer ratings of satisfaction with the care that they received, and greater patient-reported difficulty with following through with the treatment recommendations. So even if we are able to overcome our biases and do all the right things and do all the appropriate workup and make the appropriate treatment recommendations, if our patients are picking up on our bias through our communication, it's possible that they're not going to actually follow through with our treatment recommendations. And so this is another reason why our bias is important. So next, I know we're not talking about workforce diversity, but I also, as we think about this kind of level of personally mediated racism, I also want to highlight that microaggressions fall into this category. So this refers to your brief and commonplace daily verbal, behavioral, or environmental indignities, whether intentional or unintentional, that can communicate hostile, derogatory, or negative racial slights and insults towards people of color. And since we're focused on clinical care, I want to spend some time talking about how microaggressions can actually impact clinical care. So for this study, they didn't use an implicit association test, but it highlights one of the important ways in which bias can be manifested in clinical encounters. So during recorded interviews of pediatric acute care office visits, they found that physicians were less likely to ask Black children to answer questions during the visits than white children, independent of the child's age or social economic status. And so the authors hypothesized that these disparities in interactions were due to physicians attributing less competence and less intelligence to Black children in comparison to white children. So again, as you guys go back to your clinical environments and taking care of patients, I want you to think about the ways in which you are communicating with your patients and communicating with your families, and are there ways in which your biases may be impacting those encounters. And so whether it exists on the implicit, explicit, or structural level, it's really important for pediatricians to recognize that racism has important impacts on the health and well-being of children and adolescents. So research shows that individuals who self-report experiencing bias and discrimination are also more likely to report difficulty concentrating, anxiety, depression, irritability, and mind fog. They're also more likely to have cardiovascular disease, including high cholesterol, increased risk of hypertension, heart attacks, and strokes. They also have dysregulation of immune function and inflammatory responses, endocrine abnormalities, including elevated hemoglobin A1C and waist circumference and body mass index. There's also musculoskeletal symptoms such as inflammation, tension, aches, and pains. But what's particularly interesting to me is that the chronic stress of experiencing racism and discrimination can also result in DNA methylation and shortened telomeres. And then this DNA modification is then passed down to the next generation. So children of color are often disadvantaged from conception due to the transgenerational trauma from racism that's transmitted in their DNA. And so as we have spent some time talking about disparities and talking about what some of the root causes of these disparities are focused on racism, I want to talk to you a little bit about how you can be anti-racist. So anti-racism refers to policies and practices that oppose racism and the oppression of marginalized groups. So what it does is it moves beyond just not being racist, right? And beyond acknowledging the pervasiveness of racism in society, to actively dismantling the structures that uphold racism in order to promote racial justice. So I like to think of it as a bell curve when I think about my colleagues, right? So I think that we have some individuals, unfortunately, who are actively racist, right? I hope that we can get to a point in our society and in the field of pediatrics where we don't have those individuals, but the reality is that they exist. And I want you to think about those individuals, right, when they're making inappropriate and overtly racist comments, and what your role is in calling those out and no longer accepting them, right? So you have some individuals who are racist. I think the majority of us in healthcare, right, the majority of pediatricians are right in the middle of this bell curve where you're just not racist, right? And within that that group of people who are just not racist, unfortunately, there's a lot of white fragility around issues of racism, and I'll define that in a moment. But then you have some of us on this other end of the curve who are anti-racist. And so my goal is that through discussions like this and through some self-reflection and education on your own, that you will, I don't think I'm going to be able to impact those who are overtly racist, but I think the majority of pediatricians who are right here in the middle, my goal is that you can advance beyond just not being racist towards actively being anti-racist. So I want to briefly just talk about white fragility because that comes up for a lot of our just not racist providers. And so this refers to your discomfort and defensiveness on the part of a white person when confronted by information about racial inequity and injustice. It may be coming up for a couple of you guys who are listening to this presentation right now. And some of the ways it can manifest is by weaponizing hurt feelings, often with tears and implied expectations of apology or comfort. Or individuals describing how hard it is to navigate racism, completely clueless to the toll that it takes on a person of color who's experiencing it. And the reason why it's important is because the impact of white fragility includes perpetuating a system of racism, and it often prevents open discussions of the impact of racism on everyone. And oftentimes it extracts further physical and emotional labor from people of color, which can often cause further harm and trauma. So if you don't take anything else away, I just hope that when you leave here, please do not take your white fragility back to your institutions and back to your Black colleagues at the end of this presentation. And so as we kind of wrap up to starting to begin a dialogue talking about solutions, I think about the poet Audre Lorde, who I've been turning to a lot these days. And she wrote and spoke about the transformation of silence into language and action. So for decades, pediatricians in our organizations and our institutions, we were silent when it came to using the R word. For many of us who are doing the scholarship, literally, it was often edited and taken out and whited out of our manuscripts, right, when we're trying to publish scholarship on this. And even early on in my career as a researcher, looking at implicit bias, I was told that my research was a threat to the reputation of my institution. But I think largely due to work like the American Academy of Pediatrics policy statement on racism, led by Maria Trent, published in 2019, as well as work from the AAP Task Force on Addressing Bias and Discrimination, led by Jill Wright, we're really now starting to see that silence being transformed into language. So over the past year, we've seen unprecedented statements in solidarity that Black Lives Matter and acknowledging that racism exists. But now what we really need to do is we need more than words. So we need to see language transformed into action, because enough is enough. So now that we've spent some time kind of defining the problem, exploring the root causes, I want to start this dialogue of how you as individuals and institutions can begin dismantling racism and working towards child health equity. So first, on an individual and personally mediated racism, pediatric providers have an opportunity to examine their own biases and to consider how they may influence clinical practice, such as the disparities and analgesies that I described earlier. So while there's a dearth of evidence-based interventions to reduce bias in healthcare, practitioners can turn to some of the strategies that have been found to be successful in other settings. So for example, perspective taking refers to consciously assessing a situation from the point of view of another racial group. Research also shows that exploring common identities can help reduce your in-group versus your out-group thinking and implicit bias. Next, we have counter-stereotypic imaging, which is imagining someone from a marginalized group who does not fulfill commonly believed stereotypes about that group. Research has also found individuation is a successful strategy. So that's when one tries to get to know someone else and focus on their individual characteristics instead of their group-based characteristics, which can often be influenced by bias and stereotypes. And also in a racially stratified world where our views of others are often influenced by stereotypes, getting out of our comfort zones and increasing opportunity for cross-cultural contact is another strategy. And finally, there's a growing body of evidence showing that mindfulness interventions are effective at reducing implicit bias. So how can we kind of get our brains to have that slow thinking instead of the fast thinking that is often using heuristics that can include bias and stereotyping? But unfortunately, I don't think we're going to achieve meaningful change by just focusing on individual hearts and minds and biases. And so I would also encourage you all to take a closer look at your institutions. So some of the things that I want you to reflect on are, what are some of the policies and procedures and regulations in place that may inadvertently perpetuate disparities and inequities in care, such as like what insurers you have? And does that result in differential access to the excellent care in your organizations for individuals based on their insurance? Also think about what are some of the aspects of your organizational culture that may undermine relationships with patients and families from underrepresented backgrounds. And ask yourself, what is your organization or practice doing to make equity and anti-racism a strategic priority? So some of the things that you can think about doing. One is addressing equity through your QI projects. So when you're participating in your MOC Part 4 activities, for example, your baseline and your follow-up data should be stratified by patient race and ethnicity to evaluate for inequities in the quality of care and then promote the development of improvement plans that help reduce these disparities. And in addition to that, many of you on the call today represent some of the leading pediatric institutions across the country. And many of you have very robust patient safety and quality improvement programs. So as we dive into the discussion portion, I'd love to hear if some of you are already looking at QI data stratified by social demographic factors. And if so, what are you doing once your inequities are identified in the quality of care? And if you're not, what are some of the barriers to doing this in your organizations? And then finally, addressing racism in clinical care also really requires us to expand our spheres of influence beyond the hospital walls. So in order to do so, though, first you have to do the work. So you really need to take the time to read and listen and reflect and understand. You need to take a deep look inside and reflect on some of the ways in which you personally have perpetuated racism in society and academia, and in which your institutions have perpetuated racism in society and academia, and make an individualized learning and action plan for what you're going to do to change that. I can't do the work for you, certainly not in a 20 to 30 minute presentation. And then please do not turn to your Black colleagues and ask them to carry the burden and do the work for you of fixing racism or educating you about racism. But once you've educated yourself, you then need to go beyond the hospital walls and serve as advocates to dismantle policies that drive the social determinants of health that disproportionately impact communities of color. So one example of how you can do that is your institution can be an anchor institution supporting the economic growth in communities that have historically experienced the systematic denial of capital investments from policies like redlining. And so before I turn it over, I have a shameless plug, a commercial break, because we've talked about disparities in care, we've talked about racism, but I think that there are some really important topics that we did not have time to talk about today. And so for PAS Phase 2, the Race and Medicine Special Interest Group is partnering with the Section of Emergency Medicine Special Interest Group to present this session, The Triple Threats of Our Time, Race-Based Health Disparities in COVID-19, Adverse Policing, and Community Violence. So these are three big topic areas that are having significant impacts on all communities and disproportionately impacting communities of color. So I'm going to be presenting on police violence. Dr. Shani Buggs is a PhD epidemiologist who's going to be presenting on community violence. And Dr. Andrea Cruz is an emergency medicine physician and infectious disease doc who's going to be presenting on disparities in COVID-19. And then this is going to be followed by a panel presentation with like the heavy hitters in our field who are really doing this research and work. So Nia Hurd-Garris is going to be talking about how you address these issues from a research standpoint. Rhea Boyd is going to talk about how we address these issues from an advocacy standpoint. And Joe Wright is going to represent how we address these issues using academic medicine. So I encourage you guys to log in. This is going to be live on Monday, May 17th from 1 to 3 p.m. And so as I pass the baton, I recognize that there are so many individuals and institutions who are on this call, and we really want to start engaging in a bi-directional dialogue. So we want to hear about what you're doing to make anti-racism a strategic priority in your institutions. What's going well? What have been some of your challenges? Because this is hard work and there are going to be challenges along the way. And so to jumpstart this conversation, I'm going to pass the mic over to Dr. Bruder Stapleton, who will share a little bit about his journey.
Thank you, Tiffany. As Sarah brings up the slides, Renee and I had many discussions about the wonderful talks that have been presented at national forum, and so many of them are very high level, raising very important perspectives of the issue of diversity, inclusiveness, and racism. But very few of them, if any, have presented the kind of data that Dr. Johnson just presented us, showing very specific clinical examples of how racism affects child health and and offer ideas for addressing them. And so that was a wonderful talk. I'm going to give a very short presentation of our journey towards becoming really aware of racism, despite a strong commitment to diversity and inclusiveness. So if I can see the next slide. As chair of the Department of Pediatrics at the University of Washington and Seattle Children, we wanted to address the lack of diversity in our faculty and residency. And so we really launched a number of initiatives. One of them was one of the first minority sub-Is for our residency program. We had faculty and resident training about implicit bias. With the hospital, we created a Center for Diversity and Health Equity that frankly missed the mark at first. It's now very active and positive, but we missed the mark because their mission wasn't clear. Was it to improve staff equity, or was it diversity, or was it to change the culture, or was it to look at health outcomes? It was too broad. It's very focused now and really performing at a high level. We require diversity and inclusion training and equity training, which includes some anti-racism for all our leaders. We had a Department of Pediatrics faculty meeting devoted strictly to unconscious bias and performed IATs as a group, and had a speaker of the book Blind Spot. We also had a strategic diversity plan led by our current chair, Leslie Walker-Harding and Fred Rivara, that changed our mission statement. All that happened back around 2005. And the hospital developed inclusion networks. So we really had been working on this over a period of 10 years. And during this period, the national events, I personally became aware that I needed to educate myself more about racism. You know, that racism was not just diversity there. And so I personally underwent a self-education. As we became more diverse, our faculty were raising issues of racism that needed to be addressed. If I can see the next slide. So we became aware, and I became aware of, if I could go back to the last slide, of areas of racism in our culture broadly in Seattle. Medical students started reporting micro and macroaggressions at their graduation exits, and there were sit-ins, and we were shocked because this wasn't directed at pediatrics, but we thought we had a culture across our community of anti-racism. And we began looking at diversity, as Dr. Johnson suggested, with a new lens, looking at diversity. And this has been now an important area for our Center for Diversity and Health Equity. And we were surprised. For instance, we developed all these standard pathways, and we assumed that would eliminate differences in outcomes for different populations. And to our surprise, it shouldn't have been a surprise, they didn't. There were still differences, even though everyone received the same treatment. And one area that was really disturbing to us was our Code Purple Code Purple announcements like Code Blue, but Code Purple is for families that are aggressive or angry. And there was quite a difference between racial and ethnic groups at our hospital. And at first, we started thinking, oh, we just need to talk to security and do de-escalation. And it didn't, it was far deeper than that. And so then once we really identified this, and especially under our new leader, Dr. Walker-Harding, we have really started addressing de-escalation for the staff on the floors, focus groups with parents to find out what in our culture is making them uncomfortable, doubling down on our security, which we're also a wonderful group, very diverse and very focused on equity in their security measures at the hospital. But we're really looking at all that under our new leader, Dr. Walker-Harding. So, you know, I think these are some things that we've done, and it was an example of how, in my mind, we had very positive surveys on the improvement in our culture for diversity and equity. We had more diverse faculty and residents, but we still hadn't come to the understanding of the opportunity to be anti-racist in our culture. And so I present these just as some things that worked, some things that we're working on, and a couple of things we didn't work. And our hope is that you will share your experiences and we can learn from each other. So I'm going to turn it back over to Dr. Jenkins and Sarah, who will be moderating the questions. And I hope you'll all participate. Thank you for letting me share our experience.
So we thank you, Bruder, for the work you've done and for sharing that it's difficult work, and it's not a short run. It's a long set of planning, and it moves differently across the set of issues that there are. And we thank Tiffany for an energetic and provocative presentation that I hope people will have some comments for. So Sarah, do we see any comments or questions yet?
Not yet.
Okay, all right. Well, let's look at the questions we have here. It seems as though the first question was answered a bit by Tiffany, excuse me, on quality measures, because those are the measures of clinical relevance, and often it's a way to begin to embed issues of anti-racism in your regular kind of data that you accumulate. Tiff, do you want to talk about any of the other types of measures that people are using for quality that are helpful?
Sure. I think that it really, as I alluded to in my presentation, it begins with some of the work that we are already doing around patient safety and quality improvement. But the reality is that many organizations aren't either systematically collecting information on race and ethnicity, or when they have that information, they're not using it when they're doing their evaluations. So it begins by first collecting real data on race, ethnicity, and language. And so there's lots of variability with institutions across the country for how this information is collected. So one of the places you can start is by looking at your policies and making sure that race and ethnicity are collected through self-report and not just from a registration person looking at you and deciding what race they think. You have really good data. And similarly for language. So I know a lot of the institutions that I worked in, if you can kind of get through the triage and registration process, and with them talking to you in English, they identify your language as English. If you seem to have some trouble understanding those questions, then they'll ask you what your language is. But we really need to ask parents and children what their preferred language is, particularly for when communicating with the healthcare system. So once you have nice, good, clean data on looking at race and ethnicity and language, then you can start looking at your QI portfolios to see if there are racial and ethnic differences. So one example I'll give is from some work recently published with one of my trainees from CHOP when I was there. So Bruder mentioned that, they thought, well, we have all these pathways in place, so care must be the same. And so I'll make two comments around that. One is that we don't always want care that's the same. We don't, in order to achieve equity, sometimes it doesn't mean that it needs to be equal, right? So you need to make sure that you're giving the right resources and the right interventions to the right patient at the right time. And so sameness doesn't always get you to equity when you have populations who are starting off at a disadvantage, number one. But number two, we found that even when pathways exist, there's still sometimes differences in kind of who those pathways get applied to. So we recently published a study in academic emergency medicine looking at the management of gastroenteritis. So among patients who were like lower acuity triage, acuity like 3s, 4s, and 5s, so that we're taking out those kids who are sicker and need IV fluids, the pathway at CHOP was recommending that you start with ondansetron if needed, if the patient is having vomiting, and do oral rehydration therapy and limit the use of IV. But we found that white children who were even lower acuity were more likely to have an IV placed in comparison to Black children, despite this pathway being in place. So I think that pathways are important, pathways are helpful, but we still sometimes see that there are disparities in how providers are applying those pathways to our patients, because there's still kind of provider discretion and bias can still come into play.
And on another observation that was made, Chris Gleason shared a paper with us where zip codes were used as also a variable, so that you can see within the community where are the areas that really need more attention and where the issues are to improve quality. So it seems like quality is a really a good opportunity to take the clinical issue and really be able to look at and very often is an unintended consequence, but if you look for it, you'll see it. So I think that's really an important one.
I think that's the take-home message. If you look for it, you'll see it. And so many of our institutions aren't looking for it because they don't want to know, right? But you need to look for it. And then once you find it, then you need to start developing and planning interventions aimed at addressing it. But that's how we're going to be leaders, right? Like, so we're never going to be true leaders in our field if we're afraid to look for problems because we don't know what to do about them. But if we really want to be leaders and really have positive impacts, we have to look for it and we have to begin addressing it.
Thank you both. I do believe we do have a question. Rochelle, if you are still there, I've unmuted you if you would like to go ahead and ask your question.
Hi, so my question was kind of how do you go about getting your leadership to buy into looking at more of an anti-racist policy or exploration of the policies that are within your section or division, rather than just trying to kind of check a box regarding DEI? Or I've also seen kind of more of a delegation to others to come up with a plan when it really should be the leadership that should be driving those policies, or that they'll look at those policies.
Okay, do we have any council members who want to speak up at all before we start?
Well, I think that's a really good question. And I think that the answer really comes from trying to help leadership understand the impacts that this racist activity is having on the learners, on the community, on the faculty, and on the staff. And those sorts of examples are the way to make it a very immediate thing. I know in our particular institution, we were having problems, especially with our younger faculty and learners, on comments made by patients that were, grossly inappropriate, racist, microaggression, macroaggression. And when we actually brought it to the forefront and helped the leaders of the outpatient clinic and the leadership itself understand how hurtful those comments were and the impact they were having on the younger faculty and the learners, we actually came up with a patient rights policy. We came up with these discussion groups that Bruder actually talked about to raise the awareness amongst the faculty, and the ability of having that support available for people who have suffered that type of aggression in the clinic made a real difference. Because if it takes a day or two for it to play out, it's not nearly as appropriate as if it happens right away and people make the comments, people are right there to back them up and say that's an inappropriate comment and we're here to deal with your problem. And it really did make a difference to have those discussions. But making the immediacy and the impact of those racist comments I think makes a big difference.
Mm-hmm. So I wonder if the effort that people are putting into these statements at a senior level, because we're seeing AAMC, the AMA. I mean, these are not minor now. I just saw an NIH statement. I don't know if any of that helps or not. Do people think that helps? I think they hope it helps, but I'm not sure that it does.
So Renee, it's Valerie here. I completely agree with Craig that was a very profound first question to get. And I agree with you that it's really wonderful when a national organization comes out with a statement and shows their profound commitment to, but the reality is, I think, as I look back on my own interventions, I think it has to go so much farther than just the statement out there. And I think that's what that first question is getting to is, how do you get your leaders to really become engaged? And as you and I have talked so many times, I think the first step is acknowledging that it's not enough to just make a statement. You have to have your eyes wide open and your ears open to look around you and see where the disparities are. And I think Tiffany's advice around rolling in data into your day-to-day operations, your review of incident reports, your review of how pathways are applied to patients in a fair, reasoned manner, and so on and so forth, that as that data becomes available, if your your teams and your divisions and in your department can get the leadership to acknowledge not just the words, but the real data that's showing you that there is tremendous opportunity. And that to me is the biggest challenge in academic medicine, is for leaders to not just endorse a statement, but to endorse a real cultural revolution. And I think this kind of discussion that we're having today is really the kind of deep discussion one has to have to acknowledge your failings as a leader. And I'll be the first to say, I wish I had done more during my tenure, because I now realize just how much could have been done that wasn't.
Yeah, can I just make a comment? This is Arnie. One of the ways I think to do this, the data that Valerie mentioned, I think is crucial. We have used geocoding, for example, in asthma to demonstrate the disparities, but we've also used it to demonstrate what the issues are. That is, patients being discharged can't get their medications in a timely fashion because of the lack of a pharmacy or the lack of transportation to that pharmacy. So we changed our way of discharging patients with asthma, all of them, to make sure that they could get their medication. They received their medications handed to them by our pharmacists at discharge instead of a prescription, so that they would have the medication, they would take it, and we could reduce the disparity and readmission rate by doing that. And I want to emphasize also that I agree completely. It's not about statements. It's about doing something. We have to do things, and the leadership has to be responsible for those actions, rather than just waving our hands and saying how wonderful a statement is. That has not eliminated the disparities, which is what we need to do. So acting and doing based on data. Second point I would make is it's also about people, of course. And so listening to families and listening to those angry sessions that come from parents because they're not being treated appropriately, gives the emotional impact to the disparity that we need to recognize and also change.
Okay.
Thank you. Thank you, Arnie. We do have two questions up next.
Add one more thing to that last question about institutional leadership buy-in, because I think that that's an important piece, is that like a lot of the people who are doing this work are the people with the least power and influence, like myself. But so ways that I think we can get leadership buy-in is like what I would love to see is U.S. News and World Report has metrics around equity and disparities, right? Because then people are going to be more motivated to have change if that data is being published and that data is influencing your ranking as a leading children's hospital. So that is what I would love to see. If nobody on here is from U.S. News and World Report, we can't have that. Another thing that I would encourage you to do is just identify what your lever points are for your leaders in your institution. So a quick example that I'll give is that this summer, like immediately post George Floyd, UC Davis thought it would be a great idea to roll out a police canine unit in the hospital. And they had police dogs patrolling the emergency department. And I was infuriated and outraged, and I pulled together the literature on like disparities and the use of canines and why this was problematic, and nobody, like it was just Tiffany being an angry Black woman again. But then I had colleagues who were white and male and who were, kind of sat on some of the clinical committees who knew what the lever points were for the department. So they were able to frame it as, what would have happened if there was an incident that happened where a patient kind of was okay and then the dog got them riled up. And so they said, well, like, what would have happened if there was an injury and we would have got sued as a result of this police canine unit in the emergency department? What if the Sacramento Bee, which is the newspaper, would have gotten wind about this and this like appeared as the next front page story? So while I was trying to compel to, this is like ethically not the right thing to do, and this is what the issues are, he was able to appeal to what the leaders actually cared about. So as you guys think about advancing these issues, identify like what are the lever points for your institution and use those to try to get your leadership on board with making this a strategic priority.
Great.
Thank you, Tiffany. So we do have a couple of questions. I'm going to start with Dr. Coyne Beasley, and then Dr. Hart, and then we will go to Dr. Lucy, and then Dr. Tyler Hill. So just so you know the order, I will begin to unmute you, but Dr. Coyne Beasley, if you'd like to start.
Thank you so much for an excellent group of presentations, including the moderation. I really just want to talk about something that you've alluded to, and even Dr. Strauss mentioned a little bit. We certainly care about quality and equity because we know that there's a difference in healthcare outcomes. And I would be interested if members of the committee could actually share some of their experiences from their institutions and organizations in their efforts to actually improve health outcomes and reduce health disparities and health inequities. And when I think about this, I also want to think about it in the context of actually also addressing social determinants of health. So as leaders in pediatrics, that we think about the things that need to be done beyond the walls of our institutions and organizations that are actually impeding the healthcare process or our health outcomes.
Do we get some council members to respond to that at all?
Well, I can say something that Seattle Children's in the last strategic plan really looked at where we could make an impact in the community, and we built a brand new primary care facility that was located near a grocery store, a library, and low-income housing. And there was a very concentrated effort to say, with support of our board and the executive team at Children's, to look at a way that we could have our primary care program try to address some of the social determinants of health that were affecting our population that we were caring for. So that's one example.
Great.
And it was also near a light rail station, so people could get there easily.
Transportation.
Yeah.
Very good. Any other comments? Okay.
Yeah, I would just comment that we had an incident where there was one of the FQHCs and Medicaid provider groups that got into financial trouble and couldn't deliver care and almost folded. And we just said, we're going to take over. We're going to provide the sufficient financial resources that you can continue to operate your clinic in the needy area, so that the healthcare would be provided close to the patient. That cost probably $1 million, but there was continuity of care. And we helped them get back on their feet, and it was just, we have to do this because it's the right thing to do. So that, I think, is also an example of what sometimes has to be done to assure proximate care, quality care, close to the patients, just as Dr. Stapleton mentioned.
Very good, Ani, thank you. Next question.
Dr. Hart, can you hear? You should be unmuted.
Yes, I can. Thank you all so much. Really, this was a wonderful afternoon, time well spent. I'm so happy I was able to join, and thank you so much for putting this together. I am a pediatric hospitalist here at New York City Health and Hospitals, and also our Director of Equity, Quality, and Safety. I've been in this position for a couple of years now, and what has been very helpful for us, and what I'm curious if there's opportunities to further advance this, is fundamentally ingraining equity into quality and safety. So we really started with our quality committee, and we said we have to ask all of our sites a simple question: did structural inequity or bias contribute to this adverse event? When you start at that level, now the site leaders, CQOs, patient safety leads, have to then go and do their homework. And then we said, hey, look, we have all these quality and safety mechanisms in place. You have an RCA, you have risk managers, you have investigatory processes built in place. You need to be doing these upstream bias assessments, rooting this out so that when you do come to the board, you're prepared for these. And then our CEO came out and said, he's actually doubling down on this, Dr. Mitchell Katz. New York City Health and Hospitals were the largest safety net system in our country. He says, I actually want to tie my executive compensation and my performance evaluation to the number of equity projects that get presented to this board. So I do think it's a very strategic opportunity to utilize the historical gravitas, the well-resourced nature that is quality and safety, the QI science and change management skills and tools, and really objectively measure. Because I think for the past 20, 30 years, we've been doing implicit bias training out to wazoo, and we don't really have too much to show for it besides billions of dollars in someone's pockets. maybe consultants. So I think finding those ways to objectively measure this change over time and being able to really standardize these approaches. And I think so much that collection of high fidelity real SOGI data, and then how that informs, disparities analyses, but then also using the safety infrastructures that we have in place to be able to, look at RCAs at the implicit level, explicit levels, institutional level, how we do language access, how we do clinic hours, things of that nature, how we terminate patients, what insurances we accept. I'm curious if anybody has given any thought at their institutions on this about ingraining equity into quality and safety. Thank you.
Okay, thank you. I think Dr. Johnson spoke to that at some level.
Yeah, so I would say, Dr. Hart, thank you so much for sharing your experience. Because that is exactly the type of work that we're looking for organizations to do. So I'm glad that you guys can kind of serve as a role model for how to do that effectively. What I would encourage you guys to do is also publish that, right? So that you can provide a model for other institutions who are interested in incorporating equity more substantially into your quality improvement efforts. The other thing that I'll say is thank you for mentioning that the leadership making some recommendations around metrics being tied to it. So bonuses, advancement, promotion around equity projects. And so as we think about kind of making equity a strategic priority, oftentimes we see few individuals, we see the diversity tax, the brown tax, where your Black and brown faculty are the ones who are taking on this work. But it's challenging, particularly for people like me, when you're in big academic centers and your tenure and promotion isn't tied to what QI work you're involved in, right? And what advocacy work you're doing. So how can institutions who are really interested in moving this forward, how do you make it a shared responsibility among all of your faculty, right? You do that by tying bonuses to doing that work so that other people are invested into doing the work, but you also provide rewards for people who are doing good work around this so that it doesn't detract from their success in academic medicine, but it helps to advance their success in the field.
Mm-hmm. So you're looking at leverage points and incentives as part of what makes people change their behavior. That great.
Renee, if I may, this is Bob Sarwin. Dr. Hart raised the parallel between this work and quality and safety work, and I was thinking that in the early days of quality and safety, there was a lot of uncertainty and skepticism, and now we've evolved to where everyone expects it. And in fact, there's tools to measure how an organization's doing, not just the individual safety events, but the culture of safety. And I wonder if there's any work in the realm of trying to measure the culture of racism in organizations, and whether that wouldn't be a worthwhile goal to pursue. Because then you'd have some semi-quantitative data to perhaps stimulate organizations and also, more importantly, demonstrate if they're making progress or not.
So I would imagine, Tiffany, that people are thinking about that, but they haven't gotten out there with the tools yet to make that happen. I think the action element of where we are in terms of achieving equity is still now opening up research opportunities for people to have these kinds of measures. And I think next session, when we talk about research, that some of these things should come up in terms of the focus of the research. So that's a really, I think it's a really important concept, but I just think right now it hasn't been developed yet. Am I on the right note, Tiffany?
Yeah,
okay.
I think that's a strategy as we think about moving this work forward. So I like using like QI as an approach and as an example. I also think about this in terms of some of the work that's been done around like gender diversity, where like that was taboo to talk about, and now we have like efforts and metrics that are focused on it. Or even when you think about like medical education and how do you measure impact for people who are medical educators, where 20 years ago we didn't have good metrics for knowing if you're a good medical educator. And so I'm hoping that as this work is getting more momentum, we will see some more kind of evidence-based tools that we can use for evaluation. I would love to see some of our academic organizations like the AAP, who does have an equity agenda, help us to start developing some of those tools as well.
The University of Washington has now stated that they will include considerations of contributions to equity, diversity, and anti-racism in the promotion process. But as you know, they're not clear criteria. And when they're not clear criteria, it's hard to gain traction. And I think that that's what's needed. Yeah.
Okay.
Great. Thank you all. I think we have a question from Dr. Falusi.
Okay. I have some
Hi.
ringers in here, my people.
Yeah, that was fantastic. And I could listen to Tiffany Johnson and Renée Jenkins all day long. So thank you both. Thank you all for really great presentations. I'm curious, Tiffany, your research on cognitive load, the study in the ED is so compelling. And I'm wondering if there have been studies or even anecdotes of institutions that have gone that next step and trying to actualize, put some action behind that data, either looking at their clinical settings and examining those cognitive stressors, trying to reduce them, really for the sake of reducing those triggers for implicit bias. I think it's really interesting because it overlaps with a lot of what we're already saying around quality and safety, and also just with staff wellness. There are reasons why institutions may not want to do that if they're thinking about the bottom line and if there are costs associated with that. But just curious to hear if you've seen or heard of any that have looked at this from that particular standpoint.
Thanks for your question. Unfortunately, I have not, because like you said, it impacts the bottom line. And so I think that, I like to think like any emergency department, we're the hardest working docs in town, right? But the reality is that in primary care, you are also faced with lots of challenges where you are expected to see more patients and to do so much more with a very limited amount of time. And hospitals aren't incentivized to give you more time to spend with your patients so that you can actually focus on individuation, right? And have less cognitive load. And instead, we're incentivized to see more patients. So I'm hoping that we will be able to change that model moving forward. Some of the things that I personally do is I have a rule for my residents that everybody has to eat, drink, and pee before the shift is over. And I really encourage them to take the time that, you have to put that oxygen mask on first. So if you want to be able to be a good doctor, then you also have to take good care of yourself. Like we work 10-hour shifts with no lunch break built in. Right, it's crazy, and so I try to. I would love to see us having models where I don't know, maybe our unions, like the nurses, give us lunch breaks and give us those times to kind of decompress. But I'm certainly not in any position of power or authority to move that forward. But I do think the biggest challenge is going to be the bottom line, because the more people you have to kind of provide those overlaps to reduce that cognitive load, then the more money it costs to do it, unfortunately. So if you have unique and creative strategies for doing that, Laura, please share with us as we try to move this work forward.
That's why I'm asking the question. But I'd love to hear if others do look into that, and it's something that I look forward to talking to my institution about as well, actually.
Thank you.
I think that's one of those outcomes that once something really negative happens, then people will take a look at it, which is unfortunate, but.
Some of the things that we can think about doing are like using advanced practice providers. And I know a lot of institutions have done that to kind of help be a pop-off valve for like the residency workforce. For example, when you have caps to the number of patients that the residents can have, then you have like an advanced practitioner workforce who can kind of help to do some of those things. And so maybe we should start exploring using that workforce as well to help us to kind of spread the work that's being done to help reduce some of the cognitive load.
Very good. Thank you.
We did have another question from Dr. Tyler Hill.
Right.
Oh, good afternoon.
Hello, Yasmin. Yes. Okay.
How are you, Renee? Thank you all so much for this. This has just been just so enlightening and so wonderful to hear the terms anti-racism being used and bandied about. And I wanted to take this in a little bit different way of really working to make structural changes, because I know all of these things we are doing are at the whim of really how the system works. Mm-hmm. And so I want to ask this question to anyone on the dais there. Have you had any success with working with large, powerful systems to actually go at this community-based systemic and structural changes, and actually pushing that from a board level where there's a lot of power and a lot of ability to really make community-based changes?
Mm-hmm. Are you thinking about that, Bruder?
I am thinking about it. We Seattle has had, after the George Floyd murder, a tremendous self-reflection, I think. And our hospital has been part of it. Our hospital is part of a university, which is very aggressively started working on anti-racist measures. And our leader, Dr. Leslie Walker Harding, has been speaking on a number of business panels. And so we are actively involved as a department and university in the community. The community is reassessing this, policing and response to 911s, and so there's a lot going on that we're part of, and our board is very much supportive of those efforts. So I don't know if that answers it, but I see our hospital as being very proactive, but also because of some publicity about one of the outcome measures that we were trying to address has been raised, and then the hospital's under scrutiny now because we've identified that. And so it's right now our hospital is kind of looking more internally in terms of how we can become an anti-racist organization and improve whatever racist policies we have, as much as we are looking at the community.
And I'll say a couple of things. So one is, I'm grateful to Bruder for kind of sharing his experiences and being honest and open and transparent about some of the things, the good and the bad and the ugly about the work that's being done at Seattle Children's. I'll say that I think Seattle Children's has done some really great and important things that have been models for other institutions in the country. But the reality is that like racism exists everywhere. And so even though Seattle Children's made the front page of a paper, it exists in all of your institutions too. So I would encourage you, who are all of you who are leaders on this call, to recognize that you may be the next one on the front page of the paper. And so how do you start not waiting for that moment, but how do you get ahead of it now and recognize that these issues that exist in Seattle also exist at Children's National and also exist at CHOP and also exist at like any other institution who's on this call, and what are you going to do to address them, because they've been working on it before it hit the front page of the paper, and imagine how much further behind you're going to be if if it's brought to light and you have not started working on these issues. So I would encourage you all to begin in doing this important and this really challenging work. And then the other comment I'll make is just related to Dr. Tyler Hill's question about boards, and like let's think about what the boards look like, right? The boards all look like the communities that most of our institutions are serving, and so their priorities are often not related to the needs of vulnerable and underrepresented and underserved communities, particularly when those communities are Medicaid and not bringing in substantial revenues into your institutions. So how do we evaluate? And we've been seeing a lot, definitely pre-COVID. I'm not sure what this COVID era is bringing with decreased volumes, but pre-COVID, we're seeing a lot of institutions who are working on how do we improve our payer mix and how do we create community sites that are in communities that are privately insured, while at the same time, many times neglecting the needs of the community right in their backyard. So I would encourage you to reevaluate what your boards look like. And being anti-racist means evaluating your leadership, and that leadership includes not only like your residents and your faculty workforce, but also looking at the executive leadership and looking at the composition of your boards as well.
Mm-hmm. I also think one of the things when you look at this literature is silence is not an option. That at some point, if you don't speak up, people think you basically condone the racist policy. So it's better to formulate what your response is going to be and your engagement than to wait for something to burst open. So.
We do have a question or a comment/question from Dr. C.O. Mayer. I have unmuted you if you'd like to ask your question.
Thank you so much for this really inspirational and I mean, a talk that really gives some concrete goals for all of us to achieve. So I have kind of a, hopefully an uplifting question. What would be your wish list? You know, we've had a corporate donor offer funds for anti-racism and equity work in our institution. And I'm not quite sure of the figure, but what would be on your priority list if there were funds that have become available for this kind of work?
It's Christmas, Tiffany. What do you want for your present?
So much. So I want more workforce diversity, right? So I want money to go into doing things like minority visiting clerkships, like what Bruder's been doing at Seattle Children's and then done in other places. Money to hire and pay Black and brown faculty to be a part of your community. I also like invest that money into the community, right? And so when we talked about being an anchor institution, and so what do we do? So I think there's some investment that needs to go within our hospitals to address these issues. But there are also some investments that need to go outside of our hospital walls to positively impact the communities that you're serving. And in order to know how to use that money, you need to talk to your community. So if you don't already have like a strong and robust community advisory board that like truly represents the patient population that you're serving, get together that community advisory board and ask them the questions, right? Ask them both what the community needs, but also you need to start asking about patient experiences and what's going well and what's not going well and where you need to invest money and resources. We've talked a lot about patient safety and quality improvement, and I'm glad that Dr. Hart was able to share some of his experiences at his institution. My work also requires money and resources and infrastructure. So can you invest money into that so that you can have some robust metrics around creating equity dashboards for your institution to identify what your challenges are and then funneling money towards addressing what some of the needs are and the resources that are needed based on those things that you identify through your QI work. But like I would say, number one is like give the money to your community because they're the ones that need it.
Mm-hmm. Some things to consider that we have launched at Seattle Children's and the Research Institute is we now have a full-time minority faculty recruitment officer. We have a very, very strong pipeline program for summer experiences that in the community and really trying to build a pipeline and the Research Institute has a science program that goes throughout the state to teach science. It's now, I don't know, the pandemic, it was a little slowed down. We have a lab, but they go based to schools who have a high school lunch subscription. So they specifically have gone to underserved schools all across the state to try and encourage young people in science. And some of those, it's been going on long enough that now some of those young people are going to college and med school. So
I think that's
great ideas. Thank you so much.
Okay, thank you. Good luck.
If I could hire all of you to come to my institution, I'd do it, but I think that probably won't work.
Okay, I think we're down to we're past our hour, but I think it's been some really good dialogue, and I thank everybody who was able to participate from all around the country. So that was really very impressive. So thank you all. Let me just close with a reminder that June 10th, we'll be having session 2 of this set of presentations with a focus on research. Dr. Fred Rivera will be joining us. He's a recent recipient of the St. Jim Award. So it should really be as stimulating as this set of talks. I think that's probably
Tiffany's going to be there too.
Yes, right. Tiffany will be there with Dr. Rivera. So it'll be a 1-2 punch, which should really be exciting. People will get a follow-up email that will have a resource guide that we hope is helpful to these efforts. And I think that's what we've got to share. So again, Tiffany and Bruder, it's been fantastic. Thank you so much. And again, I thank all the participants and see you in June.
And thank you, Renee.
Thank you, Renee.
Thanks,
Tiffany,
Renee.
thank you so much.
Thank you all.
Thanks for having me.
That was really, really good.
I think we hit a home run.